Now we are moving to the next relevant topic, twin cycle hypothesis, basis of diabetes reversal, for which I invite Dr. Deep Dutta. He is the senior endocrinologist running SIDA Super Speciality Healthcare in Delhi. He is a former associate professor, endo and member ethics committee, Dr. RML Hospital, 230 publications, research interest in vitamin D, bone metabolism, and member of many societies, member executive committee Indian Society of Bone and Mineral Research, member executive committee Endocrine Society of India. But I have a special bonding with him because he's a senior executive member of Indian Medical Association Dwarka, of which I was a past president. I am a Dwarka. Welcome, Dr. Deep Dutta.
Thank you so much, Deepmala ma'am. It's wonderful to see you here. A big welcome again to all the distinguished faculty and all the audience. I was really mesmerized by the last 3 talks, and I think we are ending this session, just the pre-lunch session, with the twin cycle hypothesis. Dr. Rajiv also highlighted a bit of it in his presentation about diabetes reversal. This is the in thing. So the last 2 talks by Yajnik sir and Dr. Shashank sir beautifully highlighted first of all, the role of B12 is not just neural health. We learned a lot, the pleiotropic role from head to toe. And Dr. Shashank sir, he highlighted the different metabolic subtypes of type 2 diabetes in our country. So this is a slide in nutshell what is twin cycle hypothesis. You can see the 2 wheels of the cycle. One is the liver cycle wheel in the front, and one is the pancreas cycle wheel behind. And there are a lot of I would say lipid parameters, inflammatory markers, and cytokines which are linking both these 2 cycles. And when things go wrong with this cycle, we develop type 2 diabetes. In simple word, if I have to summarize, just as we know that our car runs on petrol, the fuel for a human body or any living organism is glucose. And same glucose, when it goes very high, it causes diabetes and damage to body parts. And just like we store petrol in the gasoline in the tank, we have tanks in our body to store the glucose. The main tank is the liver, which is the currency tank. Immediately it releases glucose within a short period of time. And we have the bigger tanks, which are the backup tanks, which are the muscle and adipose tissue. Type 2 diabetes is all about manhandling of glucose by these tanks. Somehow they refuse to store the glucose. Like insulin is the key for this tank. It drives the glucose into the liver to make glycogen for short-term currency use, the cash, and it drives them into the muscle and adipose tissue for long-term backup uses, like you can say gold coins or something more hard. So our understanding of type 2 diabetes evolved, as we all know. पहले हम बोलते थे कि if we are obese, people are likely to develop diabetes. Then we realized it's not just the general obesity, we have healthy obesity, just now we discussed in the previous talk. We thought that it's the central obesity, the central pot belly are the people who are going to develop type 2 diabetes. Then our understanding further evolved, and we specifically pointed out it's the visceral fat. We may have the subcutaneous fat in the abdominal wall. That's not so damaging. It's the visceral adiposity which is driving the genesis of type 2 diabetes. And twin cycle hypothesis in nutshell talks about among the entire visceral adiposity, the 2 visceral organs, it's the liver and it's the pancreas. Their adiposity is primarily driving the genesis of type 2 diabetes. So for each one of us, we have a critical threshold of liver fat content beyond which the liver says, I am not going to respond to insulin, I am not going to store glucose. And it gets very angry. It starts making a lot of VLDL, the triglyceride levels goes up. There's a nice crosstalk happening between liver and the pancreas. There's the portal circulation, is the private talk, not the systemic circulation. And this angry liver sends some angry cytokines down all the way to the pancreas. And the pancreas, which was beautifully secreting, increasing the load of insulin secretion as the insulin levels were going up, because the liver is not responding to the pancreas, the insulin levels. The pancreas was making more and more insulins. But now the liver is really angry. It is sending some bad signals down to the pancreas, the VLDL level, the cytokines, and the pancreatic fat also starts going up. So the second part of the cycle gets started. And once a critical level of pancreatic fat content is reached, the pancreas shuts down or gradually brings down the insulin release. So you have a beta cell dysfunction also taking place, and a person who was managing with a one wheel working for some time, when both the wheels stop working, a frank overt type 2 diabetes precipitates. So the fulminant phase would have been lasting for 8-10 years, but suddenly people come with osmotic symptoms, weight loss, cachexia with a HbA1c of 10 or 12. So which is not uncommon we see in our clinical practice. This in nutshell is the twin cycle hypothesis. Now what is that critical level of hepatic fat? What is that critical level of pancreatic fat when all this disturbance happens? It varies. It depends on the genes, जिसे हम तकदीर कहते हैं. तो हमें क्या genes मिले from our parents? If you have got good genes, if there is no family history of diabetes in my father or mother, I perhaps would have a slightly higher critical threshold for hepatic fat and in turn pancreatic fat. If I have a very strong family history of diabetes in my parental side, both parental side, I am genetically challenged, and on top a modern lifestyle, hectic lifestyle, no exercises, high carb load diet. Dr. Rajiv highlighted the importance of cutting down carbs. The STAR studies beautifully showed that Indians, irrespective of what language we speak, whatever difference we may have, what unites us is our love for carbohydrates. 60 to 62% of our meals are made of carbs. With the advent of Western food habits, it is more and more refined carbs. I think that is driving the diabetes pandemic in this part of the country. The Whitehall study I just like to highlight, it showed beautifully over a period of many years, patient was metabolically compensated, and suddenly one fine days, over a period of few days to weeks to months, fulminant diabetes precipitated itself. The diabetes levels, blood glucose levels went up. So as Yajnik sir highlighted and Dr. Joshi also highlighted, that we have increasingly recognized the role of liver as a genesis or cause for development of diabetes. We were thinking as fatty liver as the sixth complication of type 2 diabetes, and now we have moved it from complication. Of course, CLD, the most common cause of end-stage liver disease or chronic liver disease or cirrhosis is diabetes, but now we have recognized the damage starts even before the onset of type 2 diabetes. So next time when we see a report of a patient going for the routine whole body checkup and comes with an ultrasound report of grade 1 fatty liver, and occasionally when we see an ultrasound report, the radiologist reports fatty pancreas, we should not just brush it away. These are red flags for the patient, and we as treating physicians should be more aggressive with these patients. The twin cycle hypothesis has told us be more aggressive with this patient in terms of instituting a stronger, more effective therapeutic diet and lifestyle changes so that we can actually prevent diabetes in these individuals. So as we see here, this slide shows that even with only a 2% increase in body weight, this study way back in 2012 in AJCN showed that some people may have as much as nearly 27% increase in hepatic fat. So the patient may appear metabolically healthy, clinically healthy, a normal BMI. As Yajnik sir just now said, the Astomese cohort, just BMI 23, and their body fat distribution was not different as compared to the non-diabetic people in that Eastern India population, but still they had type 2 diabetes. Maybe they had a greater amount of liver fat, we need to look into it. Maybe they had a greater amount of pancreatic fat, we need to look into it. So this is the story. A fatty pancreas, a fatty liver, angry liver, not responding to insulin, more of triglycerides and VLDL coming up, going to the pancreas, causing inflammation at the level of pancreas. But the good thing is when we talk about twin cycle hypothesis, at least in the initial few years, it is reversible. So once you cut down the insulin resistance, start exercising, control the diet, institute strong therapeutic diet and lifestyle changes. You may choose whatever. You may use a keto diet or paleo diet, a low carb diet. You start running, whatever you may choose. You may use insulin sensitizers like metformin. A lot of it can be reversed when the person loses body weight. He loses the hepatic fat also. He loses the pancreatic fat. But we should remember, it is very difficult. It's not easy. We need to work really hard to lose that resistant fat which is there in the visceral tissue, more so in the setting of liver and pancreas. So this is actually a real patient I would like to share with you. She is a young lady, just 24-year-old lady, and she had diabetes, type 2 diabetes diagnosed at 21 years of age. Let me tell you, I think we are seeing in our practice, unfortunately, kids of class 7, 8, class 9 or 10 giving board exams, with acanthosis, they are being diagnosed with type 2 diabetes, not type 1, which was perhaps unheard of even 15 to 20 years back. So something is wrong. We need to do something about it really aggressively. This lady, if you see her BMI, she is morbidly obese. BMI is 47.9, and she was on a pretty high total dose of daily insulin, premixed insulin, full dose of metformin, a full dose of sulfonylurea, and she could achieve an HbA1c of 7.4. So yes, she was able to bring down her initial HbA1c down, but she was not comfortable. So we needed to do something about it slightly differently. So we highlighted, we sat down with the patient, she had some counseling sessions that please you need to work on your lifestyle, you need to take some time out for yourself. We all have 24 hours, we all try to be superhumans in our day-to-day life, we juggle from work, home, family. At the end of the day, we all need to take some time out for ourselves. We need to delegate our responsibilities to our family members, to your colleagues in the office. There's no point being superhuman, there is no point being glorifying being a superhuman. That will take a toll on our health. As we are seeing, we as doctors are perhaps no more immune. We as doctors perhaps have some of the most erratic and hectic, unhealthy lifestyle. So we need to start looking at ourselves also. So this lady, what did the trick was a good therapeutic diet and lifestyle change and not medications, let me tell you. She was, with weight loss, she was gradually able to taper insulin off and go off medications. The medications are primarily supportive here. We use medications which are going to help us lose weight, like a SGLT2 inhibitor. We know canagliflozin is a dual SGLT2 and SGLT1 blocker. So there is a lot of data to show that the weight loss properties with full dose of canagliflozin is much better than the other peer SGLT2 inhibitors. We used orlistat. We know not a lot of patients do tolerate orlistat, but if they can tolerate orlistat, that can cause reduced fat absorption from the gut. So these medications are short term. They are just to motivate the patient. So even if they lose initial 4-5 kilos, it gives them such a big psychological boost. The rest of the job, they do it yourself, and you can even taper and take off the medications. So these things need to be discussed with the patient, that these medications are not for lifelong. Lot of myths in society. एक बार diabetes की दवाई शुरू होगी, lifelong चलेगी. ऐसा नहीं है. I mean, a twin cycle hypothesis teaches us that at least in the initial few years of type 2 diabetes, if you can reduce the hepatic and pancreatic fat content, you can actually reverse the early onset type 2 diabetes. Well, this has already been happening. We have been talking of medical remission of diabetes. The surgical remission of diabetes was already there. Whether the patient was undergoing a sleeve gastrectomy, or a gastric balloon placement, or a more aggressive malabsorptive procedure like the Roux-en-Y bypass surgery. What they were doing, that a person who is not motivated or not able to control the diet, a surgery creates such an altered physiologic state that the person can't eat. The patient is on a closed liquid diet for the initial 2 weeks after surgery, then semi-solid diet for the next 6 weeks, and solids comes after 6 to 8 weeks. That brings about a drastic change. The extremely low calorie state brings about drastic change, and again in them a significant reduction of not only the whole body weight, reduction in pancreatic fat and hepatic fat does make the job of diabetes reversal happen in these patients. But it's not all hunky-dory. If after a few weeks or months, if they regain, and there are patients who regain the body weight back after 1 year or 2 years, type 2 diabetes again reappears. So the story again is always lose body weight. How you want to do is again patient-centric approach, good therapeutic diet and lifestyle changes, a use of medications which are going to help us lose weight. GLP-1 analogs, they do great things in some of these patients, and of course in the end we have metabolic surgeries. I think counterpoint study was shown by Dr. Rajiv in his presentation also. I think that also beautifully showed that in people living with type 2 diabetes in controlled environment, given very low calorie diet, less than 800 kilocalories per day. Practically, if you have to give somebody 800 kilocalories or less, we have to just give meal replacement. It is not possible to give a proper 3 meals to restrict the calories to such drastically low levels. They are typically done in controlled, observed environments, but they could show that in these people living with type 2 diabetes, they were able to reduce the blood glucose to normoglycemia very effectively. They were able to stop the medications in these patients, and if you can see, they documented the hepatic fat content, they were able to reduce it. So again, the twin cycle hypothesis has come now because we have put all the dots together, but the plotting of the dots started way back, nearly I would say 15 to 20 years back. So the counterpoint study beautifully showed how the pancreatic fat gradually came down and how the beta cell function and the insulin secretion improves. So now gone is the story of absolute beta cell loss. Now we talk of beta cell pliability, beta alpha switch, and beta alpha beta cell de-differentiation. So if a person can institute a good therapeutic diet and lifestyle change and lose body weight, I think the beta cells are happy to come back and do their own job. So they lose their anger, they become happy beta cells again. So this I think we have already discussed. So this is again what the twin cycle says. A liver cycle of increased hepatic fat because of a high carb driven process makes the pancreas also angry and makes a fatty pancreas. So the problem remains here, how do we assess liver fat? Unfortunately, we don't have very easy tools to quantify liver and pancreatic fat. We have ultrasound, it is operator dependent and not very accurate. It is a qualitative tool for assessment. Typically we get fatty liver only when 30% of the liver is already fatty. So it's not a very sensitive tool to pick up liver steatosis. We have FibroScan, which is a semi-quantitative tool of assessment of liver steatosis and more so the liver stiffness of fibrosis, which is happening as a part of progression of liver disease related to metabolism. You have MR spectroscopy. It's a very reliable tool. Even when the liver fat content crosses 5%, it can pick up fatty liver, but then it's a very costly tool. It is not very easily available. So what remains is to use twin cycle hypothesis in a clinical practice on a day-to-day basis. We need better radiologic or serologic tools to pick up fatty liver fat content increase and pancreatic fat content increase. Till then, as Yajnik sir said, I would like to quote him again, that we use a good clinical jurisprudence, look at the metabolic profile of the patient, don't ignore the routine ultrasound report patient, take a good metabolic history, a metabolic pedigree of that patient, that would really help us. So direct study was already highlighted. This also showed the same thing. It showed that people living with type 2 diabetes for 4 to 5 years, when they were put on an extremely low calorie diet in UK, and those who lost the body weight, they were able to reverse diabetes. And what was the reversal? What happened exactly? People who lost more than 15 kilos of body weight, they had nearly 70 to 80% chance of going off diabetes medications for 3 months, and their HbA1c continued to be below 6%. People who lost only 10 to 15 kilos of body weight, the numbers were low. Only around 50 to 54% patients were able to go off diabetes medications. People who lost only 5 to 10% body weight, only 1/3, 30% odd people were able to go off medications, and virtually nobody went off medications if the weight loss was less than 5 kilos. So there's the quantum of weight loss is important, and what is also important is that the next 1 year, this is the 1 year follow-up data. Then they did a passive follow-up of this patient, not a very intensive, but just a passive follow-up for another 1 year. The 2 years data showed that people who regained the body weight, the diabetes reappeared, and it showed that people who lost 15 kilos or more after first year of follow-up, those who regained less than 5 kilos weight, means those who continue to have a more than 10 kilo weight loss from baseline, they continue to be in diabetes remission. So it's a continuous process, it's a continuous fight which we are fighting with our own body, with our own metabolism, and it has to continue. It's, I would say, a friendly flight and not a very atrocious flight, because if we start taking care of ourselves, our body system starts falling in place. So this is what this beautiful paper in Lancet highlighted, how the role of hepatic and pancreatic fat content in the genesis of type 2 diabetes and also the role in diabetes reversal. A small paper we published from our cohort in IJEM, wherein we analyzed the data, 3-year data of 5,300 odd people in Dwarka, New Delhi. Look at the mean BMI. These are all people who just walked into our center. The mean BMI was 27.74. So we know for Indians, we are metabolically challenged. Our normal BMI is less than 23, and here the mean BMI was 27.74. If you look here, people with normal BMI was very, very low. If you see here, nearly 60% of them were obese, 8% of them were morbidly obese, 68, 69%. If you put in the overweight people also, that's like nearly 80, 83%. Only 13% of people had normal BMI. So we as a city in Delhi, we are most metabolically challenged, and we are virtually everybody obese. Even I also fit in the obese Indian criteria. I am not a normal BMI criteria, so I need to work on myself also. I know it's easier to preach standing here than practice. In these patients, those who were diabetics, we consciously made an effort to use medications which is going to help them lose weight. Like we focused on metformin, SGLT2 inhibitors, GLP-1 analogs if possible, and of course, orlistat if you could take. And we had 500 odd patients whom we could follow up for 6 months. The 6 months follow-up data which showed that they're the first quartile, if you see people who lost 7 kilos of body weight, we were able to reduce their medications and they virtually had a normal HbA1c of 6%. And we have all sort of people in the fourth quartile people who took so many medications in spite they put on weight. When they put on weight, their HbA1c did not come down. So again highlighting, medicines are not magicians. Without good therapeutic diet and lifestyle changes, however costly is the GLP-1 analog or SGLT2 inhibitor or metformin, it is not just going to work. That's the key message which should go to our patients. Medicines are not magicians. You need to start working on yourself. So I think I like to end my presentation. This is another slide which showed how people with type 2 diabetes are more metabolically challenged as compared to euglycemic people. They had a greater surge of postprandial lipid parameters, especially triglycerides, against all surrogate measures of metabolic challenge in people living with diabetes. We can use paleo diet, we can use keto diet, we have vegan, we have made vegetarian paleo and keto diets also. It's a patient-centric approach. So I think to end my presentation, I would like to summarize by saying that twin cycle hypothesis highlights and teaches us that it is the critical threshold of hepatic fat increase and pancreatic fat increase which is driving the diabetes pandemic in the 21st century. Thank you so much.
Thank you, Dr. Deep, and like always, you have explained it very nicely and in very simple words about this reversal phenomena. Just one thing I would like to ask that, how do you place FIB4 in your day-to-day clinical practice? Like getting MRI done or getting an elastography done to each and every patient is very difficult. So is it not possible that we analyze the patient on a FIB4 score and then afterwards we can do a MRI or
Absolutely, we should not be doing this. This talk is not to highlight the use of MR spectroscopy or fibroscan, not to be done at all. They are still experimental purposes, they are being standardized. The result is not going to help your treatment practices, so why do that test? Very simple.
Next, like you mentioned about the keto diet. So do you really think that keto diet will change the fatty liver? Means because what studies say that it may sometimes increase the fatty liver, decreasing the weight so early and swiftly.
So, very nice question. Again, one thing doesn't suit for all. There is so much of variability. It's patient-centric approach. There are people who are shown to have transaminitis following using keto diet. The lipid parameters go bonkers sometimes. So it is highly individualized, not for all.
Dr. Deep Dutta, next question is you have conducted any study in which there is fatty liver? Because we are seeing lot of patients of fatty liver by ultrasonologist. Is there any study which indicate that a person is having fatty liver of grade 1, grade 2, grade 3 and you have followed them? How many of them has developed diabetes? Because in twin hypothesis, it is said that when the fat is deposited in the liver, it spills out to the pancreas and it damages it causes inflammation of the beta cells of pancreas and that leads to diabetes. Is there any study?
So I have not done study, but there is enough literature available in PubMed. You can go online. There is good Indian data available also to show that people with fatty liver disease, they have a much higher risk of progression from normoglycemia to pre-diabetes or pre-diabetes to diabetes. I would like to quote my teacher, Professor Sachinath Mukhopadhyay of IPGMER Calcutta. He is actively working in this area. He has highlighted the role of a hepatokine called fatwin A molecule. The people who have higher circulating levels of fatwin A molecule, even if the ultrasound reports are normal, they have a higher risk of progression to type 2 diabetes. He has highlighted the role of toll-like 4 receptor polymorphisms. He is now actively working to develop a molecule which is going to lower the fatwin A levels. It can be a newer armamentarium. So we have actually more and more research coming. More and more pharmacological therapeutics are working to develop agents which tackle the hepatic fat. We may have newer agents to tackling diabetes in this area.
Is MRI of abdomen is
Okay, can I make a comment, because I'm going to say again about DOHAD. 30 years ago I had this, in retrospect, a brilliant idea of measuring liver and kidney growth in utero in the Pune maternal nutrition study. And after 20 years, when we analyzed pre-diabetes at 18 years, what we find was people who were pre-diabetic at 18 years had poor liver growth in the third trimester. So that's the statement one. And second is, those who were pre-diabetic and had slower liver growth in utero in third trimester, but they had a rapid increase in size of the liver between birth and 18 years, because we measure liver serially. Unfortunately, we don't have MR spectroscopy, and on ultrasonography, only 2% of these had fatty liver by comparing the density against kidney. But it again suggests that there are pre-fatty liver stages which are based on the disparity of growth of in utero undernutrition and postnatal overnutrition. And fatty liver disease is one of the best example. Pune Maternal Nutrition Study is the first time in the world that anyone is reporting intrauterine liver growth failure as a predictor of future diabetes. Unfortunately, we couldn't measure pancreas in utero because it's just too difficult. And I suspect that's also partly a surrogate for pancreatic growth failure. In the clusters paper which we have done and now we are publishing is genetics, a gene risk score for liver lipids actually is strongly associated with two clusters in our study. So though we can't demonstrate it, genetically you are able to show it. And as I said, you use the Mendelian randomization model, which we might talk sometime in detail. Actually, you can demonstrate that these pathologies are already happening. So that liver story is very intriguing. Pancreatic story is even more interesting. And in India, like myself, Mohan, we all started our career investigating so-called tropical calcific pancreatitis. And there are subclinical varieties of that. And that probably adds to the problem. And therefore, we are now launching our own trial in collaboration with Mike Lean, who is the first author on the direct trial. I am going to call it indirect trial because it's Indian direct trial. So it will be an indirect trial report. You will hear about it in next 1 to 2 years.